Welcome to Stroke News. Today's topic is one that is quietly revolutionizing the way we treat stroke patients around the world. For decades, one drug dominated acute stroke care, but in 2026, a new generation clotbuster is taking its place. We are talking about Tenecteplase and why it may now be the new gold standard for stroke thrombolysis. For over 30 years, alteplase, also known as TPA or tissue plasminogen activator, has been the go-to clot-dissolving drug for acute ischemic stroke. Given within 4.5 hours of stroke onset, it works by breaking down the blood clot, blocking blood flow to the brain. But alteplase has its drawbacks. It requires a complex dosing calculation and must be given as an initial bolus followed by a full 60-minute intravenous infusion. That is a lot of time in a condition where every single minute counts. Enter Tenecteplase, simpler, faster, and smarter. Tenecteplase is a genetically modified version of TPA. Scientists altered 3 amino acids in the molecule to give it a much higher affinity for fibrin, the protein that forms blood clots, while making it far more resistant to natural inhibitors in the blood. The result? A drug that can be given as a single intravenous bolus, injected in just 5 to 10 seconds. No infusion pump, no 60-minute drip, just one simple weight-based dose capped at 25 milligrams. In a stroke unit, that kind of simplicity is truly transformative. But does it actually work? What does the evidence show? Multiple large clinical trials have confirmed that Tenecteplase is at least as effective as alteplase, and in some key areas, it appears superior. The original trial from China found that 72.7% of patients treated with Tenecteplase achieved an excellent functional outcome at 90 days, compared to 70.3% with alteplase. Importantly, 90-day mortality was also lower in the Tenecteplase group, 4.6% versus 5.8%. The ATTEST-2 trial in the United Kingdom and Europe, published in the Lancet Neurology, enrolled over 1,800 patients and confirmed non-inferiority. The ACT trial in Canada, studying 1,600 patients across 22 stroke centers, came to the same conclusion. Tenecteplase performs at least as well in real-world settings. A major 2025 meta-analysis pooling 12 randomized trials and over 7,500 patients found that Tenecteplase significantly improved rates of excellent functional recovery. And when it comes to reopening blocked blood vessels, a key measure of effectiveness, Tenecteplase achieved complete recanalization in 71% of patients, compared to just 43% with alteplase. In 2026, the American Heart Association and the American Stroke Association elevated Tenecteplase to a Class 1 recommendation, the highest level of evidence, meaning it is now officially an equal alternative to alteplase for treating acute ischemic stroke within the 4.5-hour window. For patients with large vessel occlusion, where a major brain artery is completely blocked, Tenecteplase is now particularly recommended. The United Kingdom's National Institute for Health and Care Excellence also endorsed it following the ATTEST-2 results. What does this mean in practice? Hospitals can now choose to stock and use Tenecteplase as their primary thrombolytic agent, simplifying protocols, reducing room for dosing errors, and potentially saving more lives, especially in settings where speed and simplicity matter most, such as ambulances, rural hospitals, and inter-hospital transfers. One important caution, however: not all doses of Tenecteplase performed equally in trials. A higher dose of 0.4 milligrams per kilogram, tested in more severe strokes, was associated with higher rates of bleeding into the brain, and that trial was stopped early. The correct and approved dose is 0.25 milligrams per kilogram, with a maximum of 25 milligrams. Doctors must adhere to this dosing to ensure patient safety. So what is the bottom line? Stroke treatment is evolving rapidly. Tenecteplase offers a simpler, faster, and equally effective alternative to the drug we have relied on for 30 years. Its single bolus administration, better clot-busting profile, and strong clinical trial results make it a compelling choice for stroke teams worldwide. If someone experiences stroke symptoms, sudden facial drooping, arm weakness, or difficulty speaking, remember that time is brain. Every second counts. Thank you for watching Stroke News. If you found this helpful, Please like, share, and subscribe so you never miss an update. In the next episode, we will be discussing mobile stroke units, the ambulances equipped like mini stroke centers that are saving lives in communities far from major hospitals.